Move on to the next case. I welcome Dr. Neethu Pradeep. She is a retina and uvea consultant at Amardeep Eye Care Column. She'll be presenting a case on mortal masquerades.
Good afternoon to all. I thank KSOS, Risha Madam and Registry Madam for giving me an opportunity to present this IC. Moving on to my case. The case of a 25-year-old young male who presented to an outside local hospital with history of defective vision in the right eye over past 2 weeks. It was a painful defective vision. He also gives a history of recent onset wheeze for past 1 week. No history of any other systemic illness, no addictions. Based on all records, his best corrected visual acuity was 6 parts in the right eye and left eye examination was within normal limit, and fundus in right eye was recorded as disc edema. From the local hospital, he was advised neuroophthalmic opinion and an MRI brain and orbit was done from the hospital which showed subretinal soft tissue lesion with fluid around the optic disc and normal brain study. When he presented to us 3 days later, his best corrected visual acuity was 636 in the right eye and left eye vision was 66. Anterior segment examination revealed nasal episcleral congestion. Anterior chamber was quiet, IOP was 16 mm mercury in the right eye, left eye examination was within normal limit. Fundus examination of right eye showed disc edema extending to the peripapillary area, surface hemorrhages on the disc, subretinal fluid surrounding the disc with venous tortuosity. The peripheral examination of right eye was within normal limit, left eye was completely normal. B-scan of the right eye showed RCS thickening around the optic nerve head. OCT in the juxtapapillary area shows choroidal elevation, subretinal fluid, sciatic intraretinal edema. OCT disc confirmed the above findings. Basic blood investigation was given for the patient. His ESR was found to be normal. However, Mando came to be positive. So we did an HRCT test which showed fibrocavitary changes in right upper lobe with patchy pneumonitis changes suggestive of all pulmonary tuberculosis. At FFA ICG was also done for this patient, which showed block fluorescence correspond to the hemorrhages with increase in fluorescence and late phase disc leak. At this point of time, our provisional diagnosis was ocular tuberculosis. We started the patient on topical steroids. However, patient also had a history of 2 to 3 episodes of hemoptysis. So we referred the patient to the pulmonologist who initiated ATT and steroids. And the patient also underwent bronchoalveolar lavage, which later came negative for Mycobacterium tuberculosis. 3 weeks later, patient came to us with severe pain in the right eye. At this time, his best corrected visual acuity has dropped to 5/60. The nasal episcleral congestion was persisting and the fundus picture almost remained the same. When we pondered the history, we came to know that he was continuing the oral steroid, he was continuing the ATT, but he discontinued the systemic steroids. So we restarted him on IV steroids, but the pain got completely relieved, but there was no improvement in vision. The current scenario is that the ocular symptoms are currently completely relieved, but there was no visual improvement, and we did a repeat investigation which showed deranged LFT. At this time, the patient started developing pleuritic type of chest pain along with breathlessness. So at this point, we had a second thought that whether we should revise our diagnosis. So we sent the patient again back to the pulmonologist. So the pulmonologist had advised repeat investigation and they did a repeat HRCT which showed well-defined heterogeneous lesion in the cardiophrenic angle. This was a lesion which appeared smaller and solid on prior CT and they reported it as evolving abscess with infiltration, and they reported multiple nodular opacities in bilateral lung field, which was a new finding. And they suggested biopsy in view of a possibility of fungal or tubercular etiology, and patient was referred to a higher center. When the patient came to us with this report, his best corrected visual acuity has further dropped to 1/60. Patient had marked episcleral congestion, pupil has developed RAPD, and the fundus picture was showing extensive exudative RD with worsening of the peripapillary region. And the patient underwent biopsy from the right cardiophrenic angle mass, which showed a moderately differentiated adenocarcinoma. The patient underwent metastatic workup, which showed an increase in size of cardiophrenic angle lesion, presence of multiple pulmonary nodules, metabolically active mediastinal and hilar lymph nodes, and iliac mets. Even though the patient was initiated on chemotherapy, on further follow-up, we came to know that the patient expired. So the take-home message is that even though uveitis as an initial presentation of metastatic cancer is a rare entity, we should have a high index of suspicion whenever there is poor response to a normal conventional treatment.
Thank you, Neethu. Madam, what do you feel? Was it only a TB manifestation, or TB later came to be a masquerade, or was it only a masquerade?
A lot of, misleading findings here. One is the age, 25 years old, starting with 6/6 vision in spite of, having the disc edema and the peripapillary involvement, episcleral congestion. So very difficult, to think of metastasis, but they do that. Very rarely tumors can incite a lot of inflammation. So it's uncommon. You generally think of metastasis as, painless, a quiet eye, but once in a blue moon they can do that. So I think it might have been just the Mets all along the way. I just wanted to know, the primary is in the lung or elsewhere?
No, primary was in the lung, ma'am.
Was in the lung.
Adenocarcinoma.
Yeah, because we a few years ago, we had a pregnant lady. That lady was, I think, in her last trimester of pregnancy, comes with recurrent episcleral congestion and orangish looking mass and subretinal exudates. Okay, really fluffy white looking exudates and SRF. So she underwent a vitreous biopsy, given intravitreal antibiotic. She improved, the subretinal exudates actually improved. And because she was pregnant, she refused to undergo a radiological evaluation, and Manto was positive. So she was started on ATT and oral steroids with no improvement. And then she was following up locally in Calicut. And then her situation worsened, and then they picked up, after she delivered, they did a HRCT test. It was a metastatic carcinoma. That kind of subretinal fluffy exudates I've never seen in MET. It looked infectious. And the primary was in the breast. Yeah, so once in a blue moon that can happen. And TB probably, this, I think there are articles, where TB is a very common thing which is mistaken for METs and vice versa.
Yeah, thank you, Neethu. And Madam, in our common practice, when, in which all situations you suspect masquerades? Because it's life-saving, no?
So, the two things, which somebody who's seeing uveitis patient is likely to come up with is the primary intraocular lymphoma, and the two common presentations of primary intraocular lymphomas. It can present as vitritis, so you might mistake it for an intermediate uveitis, or it can present with these, what you think is a choroidal lesion. It's not a choroidal lesion, it's actually a sub-RPE lesion or retinal infiltrates. If you run the OCT through it, the primary vitreoretinal lymphoma, like the name says, it affects the vitreous and the retina, not the choroid. Okay, so run an OCT to it, and typically they have that leopard spot appearance. Those lesions will have that leopard spot kind of appearance. So these cases, again, older patients, suddenly presenting with de novo inflammation and not responding to steroid therapy, you should always keep that in mind. The second one is your solid lesions. Yeah. The solid Mets, you can confuse it with choroidal granuloma. Once again, the color is a little bit different. The choroidal granulomas tend to be more yellowish, whereas this one again, typically they can be either like amelanotic lesions, or they can have the second spotty appearance. And the FFA is also different. In granuloma, you'll get an early hypo, and later the entire lesion will become hyper, whereas in mats, you'll see that pinpoint hyperfluorescence, which is persisting until the late stage. Even when the entire lesion is taking up fluorescence, that pinpoint hyperfluorescence will remain in a mat. Yeah.
And as a part of paraneoplastic syndromes, especially in lung carcinoma, can have some sort of inflammation. I have seen one case presenting as optic neuritis like picture in a case of CA lung.
Yeah, so then again, you have to keep that in mind, when you're seeing unexplained vision loss in extremes of age. You have this autoimmune retinopathy, which again can be a paraneoplastic. So you have to, sudden loss of vision, very extensive outer retinal layer loss, you might have to look for occult malignancies.
The take-home message is whenever you treat a case of uveitis and the inflammation is not resolving as you expect or it recur again and again, you have to revise your diagnosis. Either you might be missing some infection or rule out masquerades always.